चले मिनिस्ट्री से कोई आया नहीं?
ज्वाइन तो किया हुआ है 44 हो गए।
हाँ ठीक है आ गए। मिनिस्ट्री से कोई Good afternoon.
Recording in progress.
क्या टाइम हो गया?
3-4
Good afternoon. I think there is somebody from the Ministry of Health and Family Welfare who's there with us.
Recording stopped.
Sir, we have a panel from ministry. Let me confirm, sir. Just allow me a minute.
Okay, please let me know and then we'll start.
Yes, sir, sure. Sir, as confirmed with ministry, they are joining in a minute. For as of now, we can start the session, sir.
Right, thank you very much.
Yes, sir.
I welcome you all to this.
Recording in progress.
Yeah, I welcome you all to the series of panel discussions which we are holding for the last 2 weeks. This meeting is normally chaired by our director, Professor Randeep Guleria. He's stuck in a very important meeting in the ministry, so I am deputing on part of him. My name is Professor Anjan Trika. I am from Department of Anesthesiology, Pain Medicine and Critical Care. And my other panelists are Dr. Anand Mohan, Professor of Pulmonary and Critical Care and Sleep Medicine, Dr. Manish Suneja, who is an additional professor in medicine, Dr. Kapil Dev Soni, who is an additional professor of critical care and intensive care at the Trauma COVID Center, who's sitting on the right of me, Dr. Neeraj Nishchal, who's again an additional professor of medicine, who would be joining us from his room. And we would have along with us clinicians from State Center of Excellences. We would have office bearers and members of IMA from various parts of the country. And our attendees would be district level, public and private health facility representatives who would join us. The attendees cannot really ask us questions directly. They'll have to raise their hands and put their questions on the chat box, and then we'll take them up. We would be generally moderated by Dr. Professor Rajiv Kumar, who's our sub-dean and who's handling the whole show for the last maybe now 1 year. I welcome you all, and I think in the series of lectures followed by the discussion, today's lecture is on post-COVID management. And this is one issue which has now been hotly discussed after the second wave and now the third wave, and what's going to happen to us after the third wave. We read about it and we are aware of a lot of complications which are taking place after COVID. There were a few celebrities who really had a cardiac arrest after the second wave because they went back running on the roads and going to the gyms. And there were some reports where people had continued to have dyspnea and they had some psychiatric disorders. There were a lot of issues which were happening in India and as well as in England, and reports coming from Australia, New Zealand, and USA. To talk about this, I welcome Dr. Saurabh Mittal, who's an assistant professor in the Department of Pulmonary Medicine, Critical Care, and Sleep Medicine. Dr. Saurabh, please.
Thank you, sir. Good afternoon, everyone. So in next 20 minutes, I'll be discussing about the post-COVID management. So if we look at what is post-COVID? So patients who have been infected with SARS-CoV-2 virus, they may experience new, recurring, or ongoing symptoms several weeks after the acute phase of infection has passed. So in the broad terms, it is being called as post-COVID conditions, because it is not one system. It includes a lot of conditions. So the broad term is being given is the post-COVID conditions, which basically mean that the individual has a lack of return to a usual state of health after they have recovered from the acute COVID-19. So we have sequelae in various systems. The predominant symptoms which continue to bother most of the individuals are fatigue and the pulmonary sequelae. So lung remains one of the most common organ of serious injury in COVID-19. And COVID-19 patients who were even asymptomatic may still have evidence of pneumonia on X-ray and CT scan, and they may also have pulmonary sequelae. Severe patients who survive are at risk of developing chronic respiratory conditions. Important thing is that the magnitude of impairment in most of these patients may be small, but because we have a large number of individuals who develop these problems, so disease burden is likely to be huge to the current system in our country. Before I go further, I would like to make one thing very clear, that most of the things I will be discussing about are from the first and second waves of the COVID-19, where probably our populations were unvaccinated and the variants were more pathogenic or more virulent. So what will happen in the next wave, or what will happen to the post-COVID patients if we are vaccinated or if we have a milder variant of disease is still not very clear to us, but we have to have our history with us so that we can look forward to the current scenario. What is the definition of post-COVID condition? So post-COVID condition occurs in an individual with a history of probable or a confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19 symptoms, and that lasts for at least 2 months. So WHO says that your symptoms must persist for at least 2 months to call them a post-COVID condition, and they cannot be explained by an alternative diagnosis. So we have a phase of acute COVID, which is up to 4 weeks from the onset of symptoms. Then we have something called as the long COVID, in which 4 to 12 weeks are considered ongoing symptomatic COVID. While after the 12 weeks, the term given is the post-COVID syndrome or the post-COVID conditions. So how common are the post-COVID conditions? There have been many studies over the last 1.5 years, which have looked at the prevalence of various symptoms in patients with COVID-19 who have recovered. So the studies show very variable prevalence, but the common thing is that around 1/4 to half of these patients continue to have some symptoms. The common symptoms include cognitive impairment, fatigue, breathlessness, and headache. So these are the 3 or 4 symptoms which bother a large majority of patients who have recovered from COVID-19. Before we go further, this is one study, because now there is a lot of talk that what happens in individuals who have been vaccinated. So this study actually is an app-based study which looked at whether the use of vaccination actually reduces the incidence of long COVID. This was a prospective case control study where patients gave a self-reported data of COVID symptoms. And they looked at the risk of infection, severity, and prolonged symptoms after first as well as the second dose of vaccines. That means individuals who received first dose or those who received 2 doses, what was the duration of their symptoms. So if we look at the individuals who received 2 doses of vaccines, their probability of having symptoms lasting for more than 28 days was significantly lower. So this is only study as of now, as I could find, which tells that the patients who are vaccinated with 2 doses of COVID-19 are less likely to develop long COVID or prolonged COVID-19 symptoms. So now we look at the clinical features. So this is one of the very important slides of my presentation because it actually tells you the entire spectrum of symptoms happening after recovery from COVID-19. But if we look at the common symptoms, fatigue, headache, hair loss, dyspnea, and dysgeusia, these are some of the very important symptoms with which patient presents to us. The other symptoms include anosmia, memory loss, a lot of psychiatric features, a lot of cardiac problems, palpitations also occur in patients who have recovered from COVID-19. So it is a disorder. The post-COVID complications is a multi-system which it starts from head to toe, and almost all systems are being reported to have some or the other complication following COVID-19. Another problem after COVID-19 is the infections. So in the second wave, we had a large epidemic of mucormycosis. There are also reports of COVID-19 associated pulmonary aspergillosis and bacterial infections and secondary infections after COVID-19. So in post-COVID patients, we need to look at the secondary infections, which can include lung, which can include UTIs. For patients who were prolonged ventilated or were in ICU or hospitalized, there is a lot of risk of development of cutaneous fungal infections, cutaneous bacterial infections, as well as there are reports of developing herpes zoster after they have recovered from the COVID-19 because of their altered immune status. So we have to look at post-COVID infections as well. So now I'll be discussing in a brief about the lung sequelae because that is one of the very important reasons for these patients being disabled in their activities of daily living. So there are various names being given to this situation. Some is post-COVID pulmonary sequelae, post-COVID lung sequelae, post-COVID fibrosis. So you can use it any of the terms, but what is very important that it is a post-COVID pulmonary or lung sequelae. That means it has happened after COVID, and it is most often it is not fibrosis. So calling everything post-COVID pulmonary fibrosis is probably not the right way to call it. The second thing is how do we define them? So it includes clinical lung function as well as radiological abnormalities which constitute the pulmonary sequelae of COVID-19. So we will discuss a bit how common are these, can we prevent them, are they progressive or reversible, and is there any treatment option available to us for these sequelae, including the role of steroids as well as the anti-fibrotic drugs. So as we have discussed previously also, we can see here that fatigue and shortness of breath continue to be most important and most common symptoms and may be present in patients, more than 50% of patients who required ICU admission during their acute COVID-19. This is one study which looked at the pulmonary sequelae after 3 months, and they had almost 40% of the patients after 3 months continued to have grade 2 to grade 5 dyspnea. So this tells us that patients who are requiring mechanical ventilation or are requiring ICU admission are at higher risk of development of pulmonary sequelae. So now we see whether these sequelae are reversible or progressive. So because we do not have very large studies, so long-term pulmonary consequences remain speculative and should not be assumed. There are no definite criteria and there is very scant data. So what we have to see that what may affect the outcome of such patients who develop pulmonary sequelae. So patients who had severe disease and required mechanical ventilation, they are at a higher risk. There is also some indication because some data was the first wave where steroids were not routinely used. The patients who received early steroids during their severe disease, as well as immunosuppressants, including tocilizumab, etc., they had somewhat lesser chances of having post-COVID sequelae if they survive the acute stage. Also, some patients who have organizing pneumonia may respond well to steroids. So what we understand as of today, most of the pulmonary sequelae tend to have some degree of reversibility, but what is very clear that most of them are not progressive. The risk factors include elderly age, illness severity, length of ICU stay and mechanical ventilation, patients who have smoking and chronic alcoholism. These are some of the risk factors for development of post-COVID lung disease. So if we look at the radiology, the lung damage can be reversible, but optimum timing when we should follow this patient is not very clear. So we should at least wait for 4 to 6 weeks after they discharge from hospital or from ICU so that we can see what is happening to their radiological pattern. So this is some of the pictures of our patients. This was a patient who had acute COVID-19 where he had bilateral pneumonia. And if you look at the 6 weeks chest radiograph, it shows loss of lung volume, which is very evident on the 6-week CT scan as well. Similarly, this is another patient who had very severe pneumonia and developed some degree of fibrosis and consolidation at 4 to 6 weeks. So that means these are the individuals who are at risk of development of pulmonary sequelae. Another problem in patients is the post-COVID pulmonary embolism, which is commoner in the early part of post-COVID, that means between after 4 weeks of onset of illness, as well as after discharge. Some of them are at risk of development of pulmonary embolism. So the question is, can we prevent these sequelae? So for patients who require invasive mechanical ventilation, we have to use protective lung ventilation to minimize the ventilator-induced lung injury, which prevents probably the post-COVID sequelae. Also, smoking cessation, and the another factor which has recently emerged is the vaccination can prevent post-COVID sequelae. There was a lot of speculation during the second wave that whether the routine use of corticosteroids will prevent post-COVID sequelae in all patients. The answer is no, and there should be very judicious use of steroids to prevent steroid-related complications and infections. So now we come that how do we follow these patients who have been discharged and how do we investigate them for post-COVID sequelae. So there is a paucity of data regarding when and how to follow up. The guidelines from UK, from the BTS, British Thoracic Society, recommend a follow-up at 4 to 6 weeks for patients who require ICU or HDU care, and patients who had mild or moderate COVID, they advise a follow-up at 12 weeks. So this is a very general guideline for our country, that patients who had asymptomatic or mild disease with no comorbidities, no persistent or new symptoms, there is no need for any routine follow-up, and SOS follow-up can be done. For patients who are old, have comorbidities, have a mild to moderate disease but did not require hospitalization, they may be followed up by teleconsultation at 3 to 4 weeks. While patients who were required hospitalization and oxygen, they should be followed up at 2 to 3 weeks for presence of any sequelae or persistent symptoms. And those patients who have persistent symptoms, they should either go to a dedicated post-COVID clinic or they can go to the subspecialty depending upon the symptoms they present to the clinician. So how do we manage these pulmonary sequelae? The important thing remains history and examination. You need to monitor their saturation, perform a 6-minute walk test to look for the desaturation during walk test, and do a chest radiograph. Depending upon these results, these patients may require a CT scan of the thorax and a spirometry. And based upon that, further management plan is decided. So we need to do the symptomatic management of their symptoms as well as the other complications. So the symptomatic management for pulmonary sequelae includes cough. So we can use inhaled corticosteroids in patients who have persistent cough after recovering from COVID-19. If it is refractory, antitussive cough syrups may also be tried. For patients who have persistent hypoxemia, domiciliary oxygen is required. Another very common problem and very bothersome for patients is the fatigue. So in patients who have persistent fatigue, they need to be taught about the pacing, planning, and prioritization. That means they need to gradually increase their activity. They should plan when and how much they can do for their activities of daily living. And they need to prioritize their work so that they do not get fatigue and can do their activities of daily living. There has been a lot of prescription of multivitamin, vitamin D, vitamin B12 for patients who present with fatigue. But it is important that because these vitamin deficiencies are common in our country, specifically vitamin D deficiency as well as the B12 deficiency vegetarian diet, So prescription may be used for correction of their deficit, but whether it will help in their fatigue or breathlessness is not yet known. Another problem, that means pulmonary embolism, should be treated with the therapeutic anticoagulation. Secondary infection should be treated as per the usual protocols. Like we had a lot of mucor in the second wave, and that had to be treated with antifungals along with surgical intervention. You need to anticipate drug-resistant organisms because most of these patients are hospitalized for prolonged periods and are at risk for MDR organisms. And we should have a high index of suspicion for fungal infections if these patients have been receiving corticosteroids or have poorly controlled diabetes. So now the role of drugs. So one drug is the anti-fibrotics, that is the pirfenidone and indetane for lung sequelae. However, we have seen that most of these drugs take longer time to show any benefit. So they do not alter the ongoing inflammation. So whom to give is still unclear. There is still not enough evidence for or against the use of antifibrotic drug, and they may be used only in the research settings. Another very important drug is the steroids for post-COVID sequelae. There is no definite answer, but the common sense and the understanding suggests that steroids may help in patients who have organizing pneumonia pattern after their recovery from the COVID-19. So dose and duration is also very empirical and unclear. It varies widely between institutions. It may vary from 0.5 milligram per kg to 1 milligram per kg, and a tapering dose can be given up to 3 to 6 months depending upon the response and the radiological clearance. And we have to keep in mind that steroids are not free of side effects. So such patients who are started on steroids for post-COVID pulmonary sequelae, they need to be monitored for the side effects of steroids. So this was one study which actually looked at the benefit of steroids in the post-COVID lung disease, and they found that there was an increase in diffusion capacity as well as FVC in patients who were treated with steroids after their recovery from COVID-19. So another area is the lung transplant for patients who have extensive fibrosis and respiratory failure. They may be considered for lung transplant in post-COVID status. However, because these patients usually have comorbidities and a lot of secondary complications, so they are not really the good candidates for transplant. So there is a very small subgroup of individuals after COVID who are candidates for transplant. A very important aspect of recovery is rehabilitation, which is most often missed or not prescribed by the clinicians. You have to teach patients about diaphragmatic breathing, and which should be done for at least 10 minutes for 3 times a day. You can have airway clearance techniques for patients who have expectoration, respiratory muscle exercises, thoracic expansion exercises, and a brief general activity of walking or climbing stairs can help these patients in their rehabilitation. Nutritional support in form of high protein diet of 1 to 2 gram per kg is also required for rehabilitation after their prolonged ICU or hospital stay. So after recovery and on the ongoing pandemic, there is a role for virtual or a tele rehabilitation, which is a safe mode. So patients can be sent the WhatsApp-based videos, as well as other platforms can also be used for group therapies in tele-rehabilitation, as well as for patients who have been discharged from ICU. These patients, once discharged, they should be followed up by tele-rehabilitation on in-person OPD consultations. But there are many problems to this because of the availability of equipment technology, and a lot of our patient population is poor and cannot afford a smartphone or laptop. But still, for a significant proportion of individuals, virtual or tele-rehabilitation is a good option for rehabilitation. Now we go to the other systems in brief. So regarding the cardiovascular sequelae, like Anjan sir also mentioned in the beginning, that a lot of cardiovascular sequelae are being reported after recovery from COVID-19. Patients have fatigue, chest pain, palpitations, dyspnea. They have myocarditis and elevated serum troponins. Persistent myocarditis has been reported leading to poor dysfunction, poor cardiac function, as well as onset of acute MIs after recovery from the COVID-19 because of the inflammation ongoing as well as the prothrombotic state in patients who are recovering from COVID-19. So the patients who experience persistent or new symptoms, they should be monitored with serial clinical assessment, ECG and echocardiography. A symptom-directed lab evaluation should be done by a physician or a cardiologist, which may include use of BNP or troponin testing, and coexisting conditions should be treated as per the existing. If you have to give ACE inhibitors, there should be no inhibition to prescription of ACE inhibitors, which was the concern in a lot of patients during the beginning of the first wave of COVID-19. Now we go to the neurological sequelae: fatigue, impaired memory, headache, new onset stroke, dysautonomia, Guillain-Barré syndrome. All of these neurological sequelae are being reported after recovery from COVID-19. So some of these patients may require specific investigation, such as CPK or a nerve conduction studies or autonomic function studies. For patients who have dysautonomia, which is common in old patients who are recovering from COVID-19, you need to avoid, that means they develop orthostatic hypotension. So you need to give them fluid and salt supplementation. You may need to give them lower limb compression garments, and non-orthostatic exercise may be prescribed to these individuals. The neurological conditions such as stroke, epilepsy, seizures, headache, and Guillain-Barré syndrome, etc., they need to be managed as per regular protocol under the care of a neurologist. The gastrointestinal sequelae are not very commonly reported. However, COVID-19 has been reported to alter the gut microbiome and leading to higher chances of opportunistic infections. So for patients who have dyspepsia, they need to be evaluated. Diarrhea, if it is drug related, it can be stopped. If it is antibiotic related, you can try use of probiotics. Patients who have abdominal pain, they need to be evaluated in detail by a physician or a gastroenterologist for the cause, which can be multifactorial in patients who are recovering from COVID-19. Now we go to the psychological and the mental health issues. These are very common in acute phase, as well as patients who are recovering. Depression, anxiety, and post-traumatic stress disorders are some of these. Death of a family member in a positive family is a very distressing, because a lot of times families even not able to attend the death and have a lot of grief after COVID-19, which leads to post-traumatic stress disorder, as well as a lot of social impact on the family members. So these symptoms, they need dedicated consultation with a psychiatrist and a psychologist to improve the outcomes of these patients. So what I have discussed is some of the systems, not all, but I have tried to cover a large majority of systems which are having bearing on the patient's life. So just to conclude, we have to understand that post-COVID conditions are common. Fatigue, cough, and dyspnea are the most common symptoms. The majority of radiological abnormalities in these patients tend to improve with time. There is a probable role of steroids with close monitoring in pulmonary sequelae having organizing pneumonia pattern. Anti-fibrotic therapy has very unclear role, and the comorbidities should be addressed in detail. And a comprehensive rehabilitation program remains key to improve overall functional capacity in these individuals. Thank you.
Thank you very much, Dr. Saurabh Mittal, for an excellent kind of talk where you summarized everything in a short time. And I think you've covered a lot of systems, especially the common symptoms. Rajiv, do you have anybody trying to raise hands or ask questions, or should I start with some and people will fall in?
We do have a couple of questions, sir. There are a couple of people who've raised their hands from the attendees list. Just like to remind them that attendees will need to post their questions on the chat and they cannot be brought onto a live Q&A. So attendees need to post their questions on the chat, while panelists can raise their hand and they'll be brought on live. So I do have two questions. So let's just start with one of those to begin with. The first is, what is the role of steroids in the post-COVID situation?
I think that is one thing which was discussed, and WhatsApp, the University of WhatsApp was full of it. I would request Saurabh, who's already covered it, to talk about it again. And I'm sure you can give your recommendations, and then we can ask Anand and Neeraj to further, impress upon all the attendees, including people from Center of Excellence, where they can disseminate it further, that what is the role of steroids, and because we saw a lot of abuse of steroids. Yes, Saurabh.
Yes, sir. So steroids do have a role in patients who have recovered from post-COVID. Specifically, the patients who have pulmonary sequelae, means those who have radiological patterns consistent with organizing pneumonia, who have restrictive abnormalities on their PFT, who have exertional desaturation. Those are the individuals where steroids do have a role. The important thing is that when do we start steroids, it does not mean that everybody who is recovering from COVID at 3 weeks or 4 weeks, they need to be started on steroids. There should be at least 6 to 8 weeks gap from the onset of illness. And if these radiological sequelae and symptoms are improving, then patients should not be initiated on steroids. If they have persistent radiological shadows and progressively worsening symptoms or persistent hypoxemia, those are the individuals with pulmonary sequelae where steroids do have a role. The next question is how much and how long. So the dose is usually 0.5 milligram per kg equivalent of prednisolone, and we need to tend to taper it every 2 to 3 weeks, so that by the end of 6 to 12 weeks, we are able to. There may be some individuals who may still be symptomatic at the end of 6 to 12 weeks of steroids. So in some of these patients, low dose steroids may be given for a prolonged period if there is still evidence of ongoing organizing pneumonia or an ongoing hypoxemia or worsening on exertion. But it is a very small subgroup of patients. A large majority of patients will not be requiring use of steroids.
Okay, I think
other systems, yes, sir. For other systems, steroids, patients who have palpitations, that means palpitation is a very common symptom in patients who have ongoing myocarditis. So patients who have persistent palpitations, they usually have some or the other pulmonary sequelae as well. So steroids tend to reduce palpitation in patients who have persistent palpitation and myocarditis ongoing. But all this should be done in the consultation of a cardiologist after proper evaluation, rather than the indiscriminate use for everybody. Thank you, sir.
Thank you, Saurabh. Now, first, Dr. Anand Mohan. They have been, the pulmonary medicine department and the medicine department have been running an clinic of the post-COVID cases, and I'm sure both of them would have a tremendous amount of experience by now. And I would also request you to also comment upon what do they think is going to happen after this third phase. Would you see these kind of patients who would be discharged on steroids? Yes, Anand.
Okay, thank you, sir. So the question of steroids, I think it has been elaborated by Saurabh quite nicely. A couple of things we have to see when a person comes after recovery. We have to ideally go back and see what was the dose schedule of steroids he took when he was in hospital, how much he took, what was the dose and for how long, and what was the actual indication for that. And then we have to see whether that particular indication is actually resolving or not. Now, that also, so the temporal course of the disease has to be seen. There can be a situation when a person has come, he took steroids, say a couple of weeks back, then it was stopped, and now he has come and he's persistently short of breath, desaturating, and with abnormal x-rays. And so now we have to see what to do. Or there may be second person who is on steroids since that time of hospitalization, and maybe he's continuing on a small dose of low dose steroids since then. We have to see the level of activity in the disease and the level of inflammation. For that, we have to kind of look at the radiology. We may need to repeat a radiology again. Presence of significant ground glassing may be an indication, or appearance of new ground glass opacities on the CT scan, in this patient. So in this patient, you will need to repeat a CT scan a couple of months, say 8 to 12 months, weeks after his recovery. If that is showing increasing or fresh ground glass compared to the original, there may be a case for starting steroids after ruling out active infection. That is another important point. We should not miss any infection which may have occurred in the time being, which is also possible. Any other atypical infection. को जब occurred. And then we see the dose schedule already Saurabh has told how we have to taper it down. And if it is purely a fibrotic disease, because all desaturations don't mean active inflammation. If it is a purely fibrotic disease, then there is no need of starting steroids at that point of time. At that time, focus more on rehabilitation, breathing exercises, and remembering the fact that a significant proportion of COVID fibrosis also resolves over a period of couple of weeks to months. So a decision of steroid has to be taken in conjunction with the worsening symptoms, persistent or worsening radiological abnormalities and symptoms, and along with the radiologist also should be kind of taken into consideration.
Thank you, Anand. Neeraj?
Yes, sir. So maximum things have been covered. The only thing is if somebody has been on steroid, was doing well, and suddenly he develops new symptoms, then we have to be careful about ruling out other infections, especially the fungal ones, because we saw a lot of patients presenting with COVID-associated mucormycosis or aspergillosis. Both type of patients we saw. So in that case, if we start steroid indiscriminately thinking that the disease is progressing, then that patient may have more a problem rather than getting better. We did see few patients who improved during initial part, and after 3-4 weeks, they presented with florid cytokine storm-like picture. We had few patients, but they were very far and few patients. It's not that it was a rule, but we did have couple of patients who again required high dose of steroid and improved on that. So if we have stopped steroid before starting, we have to rule out all sort of infections which can happen in such patients. And of course, if some underlying pathology has been unmasked, say if patient had already had some ILD or lung pathology which was not big before COVID, and once he developed COVID, he decompensated and now the things have been picked up. Apart from that, the cause of breathlessness also include cardiac decompensation. So somebody who had coronary disease was decompensated because of COVID-19. So we just cannot start steroid because the patient is not able to maintain saturation or feeling dyspnea. So we have to rule out other possible causes and then decide about starting steroids.
Thank you, Neeraj. I think all three of you have really mentioned everything possible, and to summarize all, steroids are not the wonder drugs. They have all patients need not be discharged on steroids. There will be a small group of patients who would surely need steroids, but let the doctors or physicians decide it. And we all know that steroids have their own problems regarding control of blood sugar, possible of infections. One of the theories going around for such a large number of mucormycosis was rampant use of steroids in India, as steroids are available over the counter. So thank you very much. Rajiv, any more questions?
Yeah, so we'll continue on the steroids for now. 2 additional questions regarding steroids. One, if you were to give IV steroids, how long do you give it? And second, if you're shifting to oral, can you shift to JAK inhibitors instead of steroids?
Okay, first maybe we go back to Saurabh and then we come back to the panel. Saurabh?
So, sir, for IV steroids, during acute COVID, the trials have been done for 5 to 10 days. But for patients who continue to remain hypoxemic, the duration of IV steroids based upon their response. So if they are in hospital for 1 month, probably 2 to 3 weeks of IV steroids may be required depending upon their hypoxemia and requirement of mechanical ventilation. And for patients who have recovered from COVID-19 or have been discharged, there is no rule for IV. You can give only oral steroids.
Okay, thank you, Saurabh.
The second question about the use of JAK inhibitors. So as far as I know, JAK inhibitors have a role in some proven role along with steroids in patients who have acute COVID-19. But for patients who are in post-COVID state, I'm not sure if there is any role of JAK inhibitors.
Yeah, I think that's perfectly said. And as per the latest guidelines, Dysautonomia has been given a usage along with steroids in COVID patients. I would now, Kapil, what do you think? How many days of IV steroids were you giving to your patients who were in the ICU? And then did these patients get steroids IV when they were shifted to the ward before discharging?
So typically we were restricting a short course of steroids. That means we were, depending upon the inflammation and the condition of the patient, we were restricting to 10 to 14 days. So there was a variable, but most patients we restricted towards the 10 days of steroids, IV steroids in the intensive care unit. So when they were shifted to the ward, if they were persistent hypoxemia or the patients were having continuous inflammation, that we did increase the duration of steroids for a week or so, and then that it was tapered off.
Okay, thanks, Kapil. Dr. Neeraj and Dr. Anand, have you discharged patients who after steroids went on JAK inhibitors, knowing the fact that it is horribly expensive in India? Anand, please, and then Neeraj.
Sorry, sir, could you just repeat that? I missed a couple of seconds.
I must apologize to all. We are having some net problems at our end at AIIMS New Delhi. That's why we went out for a couple of minutes. Please bear with us. Anand, the question was whether you have any experience or do you discharge patients who are on steroids along with steroids or other than steroids on JAK inhibitors?
No, sir. No, we do not. And we have hardly used JAK inhibitors also. And like Saurabh said, they are only being tested along with steroids in a very specific subgroup of patients who are hospitalized. More often than not, steroids should be a short course event. That is what we'd like to emphasize to everybody, that it should be used for a short course in hospital, as already told by Dr. Kapil. At the time of discharge, very minimal percentage of patients will actually need to continue steroids, and that maybe for a couple of days and stop. In the post-COVID, because we're talking about post-COVID here, again, we had seen patients who were still on steroids for several weeks together, and because they just simply nobody stops it. But I think because of that, we had to stop it. They were getting side effects. So beyond a certain point, no need of steroids. But yes, if it is absolutely indicated, then it has to be used. So that will be a small proportion. But we haven't used the JAK inhibitors and steroids in the post-COVID period.
Neeraj, how about JAK inhibitors as a post-COVID sequelae?
No, again, the role of JAK inhibitor here was more in to prevent or stop the cytokine storm which has set in. So once everything is under control, there's no point in continuing with that. And definitely the JAK2 inhibitors we hardly used in our patients, because again, the trials which were done for this JAK2 inhibitors, they usually use low dose of steroid. In our sicker patient, the usual dose of steroid was at least 1 milligram per kg body weight, if required 1.5 to 2 milligram as well, especially in the sicker patients who were in frank cytokine storm. So definitely we don't discharge patient on JAK2 inhibitors, and the role of JAK2 inhibitors is more or less limited to the acute cytokine storm phase only.
Thank you very much. The issue came about these JAK inhibitors because it's a new medication. There's a novelty involved, and there were various groups on WhatsApp of ICUs or physicians where they talked about less problems of controlling blood sugar if they were not on steroids. That was the reason this was being promoted, but now it is very clear, and our panelists are very firm on the fact that there is no role of using JAK inhibitors along with steroids when you have discharged patients, or other than steroids when you've discharged patients. I also know, and each one of us have dealt with patients who were given IV remdesivir at home during the second surge when the problems occurred, and that IV remdesivir was given along with IV steroids. So we sincerely hope this doesn't come back, that kind of scenario, and no IV medications at home as a thumb rule. Rajiv, any more questions?
Yeah, quite a few actually. So the role of antiplatelets and anti-fibrotic agents prophylactically.
Yeah, I think that was another question. Yes, Rajiv, maybe you finish first, or should I take it?
Yeah.
Okay, fine. I think this was the next most hotly debated questions. We had our own protocols for not doing or doing things. There were a lot of prescriptions from all over India for fibrolytics and oral anticoagulants, both old and new. So let's first ask Dr. Saurabh Mittal, what does the literature say and what is his opinion, and then we go back to our panelists.
So, sir, regarding the role of antifibrotics. So antifibrotics, if you see the second wave, most patients who were hospitalized, a lot of patients were started on pirfenidone from day 5, day 6 of illness, and nintedanib also added. So they were being given during the acute COVID-19. So as of now, during acute COVID-19, antifibrotics have no role. Second comes the role during the post-COVID period. Post-COVID patients who have residual fibrosis, but which is not progressive. which is most patients with COVID-19 do not have any role with the use of antifibrotics. So this summarizes that almost all patients who have post-COVID sequelae, there is literally as of now no role for use of antifibrotic drugs. Where it can be used is a question. However, the trials are still ongoing whether a subgroup of patients may benefit from these drugs. What I understand and we practice in our department as of now is for the patients who have significant residual fibrosis and they remain symptomatic at least 3 months after the onset of their illness, they may be given a prescription of antifibrotic drug after explaining it to the patient that we actually don't know whether it will work or will it not work, but we may try it for some time. However, because the second wave has also gone for near 6 months, we have felt that it has actually not worked for most of our patients where it was prescribed, or we get patients who had prescription from outside and we continued these medications. They have really not helped in patients in recovery of their fibrosis. So from my side, the role of antifibrotic drugs is clear now. The another role is the antiplatelet medications. Antiplatelet medications have very well been studied during acute COVID-19, as well during some studies regarding the post-COVID use of discharge antiplatelet medication. But routine use of antiplatelet medication has not been found to be useful at all. So based upon the standard cardiac risk factor criteria, antiplatelet medication should be given rather than as a routine for all patients in post-COVID.
Thank you, Saurabh. Anand, do you agree with what he says, or was your practice slightly different?
Yeah, yes, sir. I do, because in the post-COVID, like he said, there was actually, I would like to say there was quite a rampant use or misuse of antifibrotics in the last year and for 2-3 months. And we saw prescriptions containing 12 to 13 drugs and even prescriptions containing 2 antifibrotics in the same prescription. So even that has happened, and all that within the patient's hospitalization. That means all within the first 1 week of hospitalization, which actually doesn't make much sense. It is an antifibrotic. It is not meant as a prophylaxis to prevent fibrosis that we all know as far as the functioning of the drugs are concerned. All of them prevent a decline in the progression of fibrosis if we extrapolate their role in the ILDs. And that is what we all did here. Practically speaking, we also know that corona infection, COVID, may resolve. Most of them, it does resolve over the 8 to 12 weeks, even if it is severe, without much of residual fibrosis. So to my mind, there is no role of giving antifibrotics across the board to say every person who comes with severe pneumonia. That would be really irrational. After say 12 weeks or so, like Saurabh said, a person with significant residual fibrosis and residual symptoms, there one may try this under watchful kind of monitoring and see for a couple of months. But that again is not evidence-proof, evidence-based. This is also something that has to be kind of a work in evolution, and we have to see the actual response.
How about you, Neeraj? What's your opinion on these 2 drugs?
Yes, sir. So we have discussed this in previous webinars as well, that the very term fibrosis, whether it should be used in patient of COVID-19, because fibrosis is a pathological term which means irreversible damage to the lung parenchyma, which is not in the case in COVID-19. So it can reverse on its own. So again, the role of all these antifibrotic is in prevention of progression of fibrosis. And here the progression in fact stops and reverses on its own. So anyway, this once a fibrosis has set in, these things cannot help anyway, even if it's irreversible. So only the role of these inhibitors is to prevent fibrosis from progressing. So anyway, these mechanism of action of these drugs and the mechanism which is seen in COVID-19, they actually do not match. So the chances of this antifibrotic helping patient is almost negligible. In fact, one of the side effects of one of the common used antifibrotic is cardiac issues. The patient can have sudden cardiac death. So indiscriminate use of these antifibrotic in such sick patient may actually precipitate some of the cardiac events, and we may actually lose these patients. So it's very important to understand that the onset of this drug takes time. So even if you use it in acute phase of COVID-19, when the patient is in cytokine storm, by the time it starts showing effect, the mechanism of the insult is already over. So none of these studies have so far proven any advantage of these antifibrotics, either in the acute phase, even in the follow-up, the situation is almost similar. So why burden a patient with a drug which is not showing benefit and may actually cause harm? So we have to be very careful whenever we use any of these drugs in such patients. We are already complicating a simple disease by using multiple drugs. So let's treat it as that, and whatever symptoms are that, based on that, one should take a call on what medication should be used. But at the moment, we hardly use antifibrotic in such patients.
Thank you, Neeraj. I think the message is loud and clear. Antifibrotics have no role. They have no role in as a prophylaxis. We hardly discharged our patient or gave them when they were in a hospital during the first and the second phase. The second part of the question was equally important, that how about antiplatelets? We know a lot of people who had COVID-19 were discharged on Disprin, aspirin 75 milligram, 150 milligram. As a policy and as a protocol, we never did that. There was only a small group of patients who were discharged on oral anticoagulants or antiplatelets. First was that who were taking it for their own basic disease. Let's say there was a stent or there was another problem, a mitral valve replacement or a aortic valve replacement. They were discharged on anticoagulants. Or patients who were likely to be bedridden for 2 to 6 or more weeks because of their basic, again, problem. Let's say a malignancy where the patient was discharged after COVID-19 and then it was used prophylactically. Otherwise, it's a big no for both these group of drugs. Rajiv, any more on this?
Yeah. So the next question continues with prophylactic medications. So the role of either prophylactic vitamin D or therapeutic vitamin D after testing the levels for vitamin D.
Okay. That's again a very interesting thing, because again, the University of WhatsApp and all the groups of intensive care and medicine on WhatsApp are filled with vitamin D. Vitamin D is supposed to be the wonder drug for everything possible. Dr. Saurabh, Mittal, and then maybe a short comment by both our panelists.
So, sir, prophylactic, I would suggest that if you have a vitamin D level which is known and low, it is good to replace it. That's all. Means no routine indiscriminate use of vitamin D should be done, which is actually being done in post-COVID, especially not in COVID, but in post-COVID, almost everybody is on routine use of vitamin D sachet or capsules weekly, which should not happen. It is good to test and then treat it, rather than, because it is very common. That's also, we have to know that it is very common. If you test them, a large proportion would turn out to be deficient.
Neeraj, do you think you were giving, do you think it is useful and you were giving vitamin D as a standard discharge recommendation?
So it's beyond doubt that all the micronutrients and vitamins which have been prescribed have no role whatsoever in overall outcome of the patient. So unless, of course, if somebody is deficient and you replace it for that reason, that's a different thing. But thinking that the complications rising out of COVID-19 is not going to happen because of vitamin D supplement, then I think it's wrong. And one has to remember that all these fat-soluble vitamins actually may cause more problems, especially if you are taking vitamin D, calcium, and patient is not taking adequate hydration. Then actually it may, in fact, Dr. Rajiv will agree that it may actually precipitate renal calculi and other things which may cause problem. So I'm sure he must be seeing such type of patients with increased frequency, if I'm not wrong.
Dr. Anand?
Yes, sir, I agree that none of these vitamins, and not vitamin D also, has been found to kind of impact the course of COVID. So we are talking about the effect on COVID per se. Otherwise, of course, if anybody knows he is vitamin deficient, which majority of the population in India is, then if you know it, then we can treat it as a routine. But to think that it is going to specifically impact the outcome of COVID or post-COVID or prevent post-COVID sequelae, I think that evidence we don't have, and we should not prescribe for that purpose. So we can prescribe as a general rule and a general routine, that's fine, but not for this particular purpose across the board.
Thank you, Anand. I think what was happening was that a lot of investigations were being asked for, and it was a standard rule to take vitamin D, vitamin B. If you could do zinc levels, people would have done zinc, selenium, molybdenum, everything possible, and then replace that also. So it's a clear message from the panel that there is no role vis-a-vis COVID-19 sequelae or development of sequelae or treatment of sequelae as far as vitamin D is concerned or replacement is concerned. Now, maybe we can ask Dr. Rajiv Kumar, who is a professor of urology, whether he is already starting seeing what Neeraj has said. More cases of renal calculus?
Not yet so far, sir. We haven't had enough time for them to develop calculi so far. But maybe the next year's webinars will come back with data on how many new stone pathologies we are seeing post-COVID. But fortunately, we haven't seen much at the moment.
Okay, right. Thank you. Maybe it's too early for them to develop renal calculi, but you never know. It has been mentioned in the literature, so you never know what happens. Anything else, Rajiv?
The problem with epidemiological associations now is that half the people anyways have had COVID. To be able to say that this happened because he had COVID is going to be extremely difficult. Unless you have a reasonably large population where you can compare those who haven't had COVID, you aren't going to find them. So associations are going to be difficult to establish. We'll take the next question. So this is now about oral hypoglycemics. So if a patient's on metformin, is it okay to continue on metformin or do you need to change it?
Does the question really mention about at the time of discharge or even in admission?
At the time of discharge. So okay, diabetics who are taking longer for recovery, how do we monitor them in the post-COVID situation? And do we need to stop metformin and shift to other OHs post-COVID?
Okay. Right, Neeraj, maybe you can take it and then Anand can add about it. Do you normally discharge patients on oral hypoglycemics or they continue on insulin if you started insulin?
So, especially in this sicker patient where acidosis can happen, lactic acidosis can happen, though I assume that he wants to know if this lactic acidosis caused by metformin may actually harm such patients. So again, whenever the patient were very sick, requiring oxygen on all, where strict sugar monitoring was required, the patients were on insulin rather than any oral hypoglycemic agent for better titration. But once the patient was stabilized and discharged, then of course we used to shift them to their previous medication. So if the patient was on metformin, without any issues, we could shift that patient on metformin, unless there was some contraindication arising because of either the renal failure or something which might have set in such patients. Otherwise, whatever previous medication the patient was on, you tried to discharge those patients on those medicines only. So the problem of lactic acidosis we never encountered, or the patient did not get worse if we continued with metformin, especially in those patients not requiring oxygen or had mild symptoms.
Right. Thank you, Neeraj. I think over the past 2.5 decades, metformin has come a whole circle. When I was an undergraduate, well, metformin came in, then it went out of favor, and then it can come back. It has been linked to longevity. A lot of people taking metformin to live long, and I'm sure now Neeraj has related to rest the controversy that you can't discharge patients on metformin after a COVID-19 infection. Anand, do you have to add anything else, or do you agree with it?
No, sir, I fully agree, sir. We have not found the need to change or discontinue metformin or any other hypoglycemic agent for that matter. We have not really encountered these post-COVID lactic acidosis kind of situations also.
Right. Thank you. Rajiv?
Right. So what would you suggest as the therapy for anosmia and dysgeusia? Does it need to be treated? And if it does, what should it be?
Okay, right. I think these were all seen in the second wave. We are not seeing it now. Maybe we'll first go to Dr. Saurabh Mittal. What do you do for loss of smell and taste? Do you have any therapy, Saurabh?
So for most of the patients who develop loss of smell, it tend to improve with time. Because it is most often it is because of the edema of the nasal mucosa and the olfactory bulb edema, which tend to improve with time. There has been studies which have looked at the role of nasal steroids to reduce the edema early, which may lead to reduction in the anosmia. However, it has not been shown useful. So there was a lot of interest initially whether nasal steroids in a particular position, this patient kind of lies down on one side and puts a nasal steroid so that it reaches the olfactory bulb near that area and it can reduce the edema to improve anosmia, but it has not been found useful. So as of now, there is really no definite treatment available for that. Although we believe that it tends to improve, but it takes even 6 months, 8 months to get better.
And loss of taste?
Loss of taste, no, sir.
Maybe Anand and Neeraj have come up with some wonder therapies for loss of taste and smell. I'm sure I'm aware of the fact that the literature does not support anything. Nothing has to be used and it will just take its own time to come back. Anand, have you used something,
Yes.
some wonder drug?
No, sir. We have not got any wonder drug for this. And fortunately, the whatever patients who came with this persistent therapy, persistent symptoms, uh, most of them actually regressed with time. So it was not that they were all persistently very severe or causing any so much of debility that we used to give some standard medications like already talked about, but there is nothing specific. Most of them within a couple of weeks, and that was a minority. They recovered within a couple of weeks, so it was fine. We had nothing specific to give them.
Neeraj, I think Saurabh did remark that it can go on till about 6 months. Have you come across any of these kind of things and what have you done?
So again, those who actually have these problems, it becomes very important for them. So if somebody has loss of taste, and sometimes patient may actually complain of very unusual taste. If they are eating something sweet, it tastes something else. So that happens. And for the patient, it becomes very troublesome. Though we may say, okay, we don't have any treatment, but I will only say that we have to reassure the patient that this is self-limiting. There's nothing we can do. And the more they think about this, they will fall into a cycle where they will more subconsciously try to find a cause why this is happening. They will start reading literature, which will not solve their problem. In fact, they will fall in a vicious cycle. So the wonder drug, which I will say is time and patience. They have to understand, okay, this is self-limiting and this will improve with time. Majority of them will recover within 4 weeks. Very rarely, it may last up to 6 months, as Dr. Saurabh just mentioned. But that is very small subset of patients. Majority will improve within 4 weeks.
Thank you, Neeraj. I think the message is clear. Nothing to be done, only reassurance. However, if you go on Google, there'll be enough therapies available, over-the-counter drugs, alternate system medicine of drugs. But as physicians and as part of this elite group, we have nothing to offer on this as far as loss of taste and loss of smell is concerned. It's only reassurance and unlikely to remain for more than a couple of months. Rajiv?
So continuing with this symptom management, what about cognitive impairment? Is there something that specifically needs to be done and how would you manage that?
Okay, I again go back to Saurabh. How often do you see cognitive impairment in the post-COVID infection time?
So cognitive impairment is a very broad term. What has been called in layman language has been brain fogging. Means the patient is unable to concentrate in the post-COVID period, which can happen in all age groups. If you look at the time to resolution of this brain fogging has also been prolonged. Means the patients who have had even the mild COVID, they had this cognitive impairment or brain fogging in the post-COVID period. But most of these tend to improve after 6 to 8 weeks. So no specific treatment is required. The patients in elderly individuals who were having mild cognitive impairment in the pre-COVID time, there is a possibility they may end up requiring some medication for their dementia. But for post-COVID, COVID-related cognitive impairment, it's only the time which kind of tends to improve.
Okay, we are aware of certain patients who, dementia and Alzheimer's and these kind of diseases which they had pre-COVID tended to deteriorate after infections. I'll ask Neeraj and then Anand maybe what do they do when you come across these kind of cognitive dysfunctions? Neeraj?
So, to be very frank, we have not encountered too many patients with these type of problems. What we notice that more the patient read about the symptoms, they tend to. But just on that note, I had COVID somewhere in October 2020, end of October 2020. And for next 2 months, I did fumble with the names. I used to forget names, which was not the case earlier. But over the time, I realized that the more I try to think about those things, I used to fumble. So from that personal experience as well, I can say unless you have some underlying neurological disorder, prior neurological disorder, or something which has been unmasked because of that, apart from that, young, healthy adults, I don't think they should be worrying too much. The more they focus on these aspects, they will fumble. And the more they try to ignore and try to focus on the work on hand, they will definitely improve on this. And this is self-limiting. I know they will say ki AIIMS people are saying everything is self-limiting, then why are we having this webinar? So it's just to reassure them that majority of these post-COVID complications, though it may be debilitating for those who are having this, but they are self-limiting. And if you don't try anything fancy, then of course that will be better for you.
Thank you, Neeraj. And I'm sure Anant will agree to this. We are saying things are self-limiting because we have gone through the scientific literature available and we talk with conviction as far as the data are available. If something is self-limiting, it is self-limiting. And I'm sure brain fogging also, you had it or you didn't have it, I'm sure we would have said it is self-limiting. Anand, how about you?
Yes, sir. So as far as psychological concerns are there post-COVID, some kind of psychological problems are relatively much more common. And the most common thing that we have seen was sleep disturbances. That was pretty common in the last 2 waves. But again, like I said, everything resolves with time. So they had sleep disturbances, then they had the anxiety levels were high, fear of the unknown. So all these psychological factors definitely happened. Cognitive impairment, actually defined cognitive impairment was not there. We had a psychiatrist coming to sit with us in our post-COVID clinic also for several weeks, and they evaluated quite a few patients. The most common things were anxiety, sleep disturbances, and transient depression. All of them improved over the period of 2 to 4 weeks with some slight medications, but mostly with counseling and a bit of reassurance and some, those what you call therapies at home, the relaxation therapies at home, etc. Cognitive impairment, I think 1 or 2 diagnosed cases were there, which went on for further counseling and psychiatric therapy. But I think that's about it. So I think psychological problems are relatively common, but they are mostly in the form of sleep disturbances, anxiety, etc.
Okay, thank you. I think we have all seen these kind of problems, more psychiatric problems than cognitive dysfunction. If I remember correctly, and Rajiv will agree, we started a online consultation OPD from the Department of Psychiatry where both patients and their relatives, because they also tended to have a lot of these issues other than cognitive function, so that they could consult our Department of Psychiatry on the phone and they could be treated or counseled about it. Rajiv, am I right? We had an OPD consultation running?
Yeah, that is true, sir. We had a teleconsultation service that was provided both for patients and the relatives, primarily for counseling for psychological illnesses. And many of them have continued for a reasonable period of time. So that is a fact.
Thank you, Rajiv.
Yeah, the next question again continues with post-COVID persistent symptoms, and cough remains one of the common ones. So what would you do for that?
Okay, I think this is now more important with the third wave. Practically every second or maybe every patient has cough after this new variant, and then it tends to continue for about 2 to 4 weeks for that. Saurabh, what does the literature tell us? What to do about it? And once the patient is coughing, is he still infected? Should he stay at home?
So first is the treatment of cough. So literally there is no treatment means data available for it, but the inhaled corticosteroids are being used for it, and they are being shown that they tend to reduce cough. So for patients who have persistent cough, do benefit from the use of inhaled corticosteroids, but also it is important that if this cough persists beyond 2 weeks, these patients need to be evaluated for alternate diagnosis, such as development of tuberculosis or other infections after the COVID-19. So for a cough which persists up to 2 weeks, the use of inhaled corticosteroids is very well can be given. But if it goes beyond 2 weeks, these patients need to be evaluated for secondary complications.
Right. So Anand, I think 2 weeks is a wonder number. If your cough continues after 2 weeks, please talk to your physician, and then maybe he takes a call on what investigations to be done or what therapy to be used. Anand, is that okay with you?
Yes, sir. Yes, sir. That's fine, sir. Initially, standard therapy for cough, because mostly it is a pharyngitis kind of an infection. So antitussives, maybe a short course of antihistaminics, and then of course inhaled corticosteroids, a short course can be given. One has to just see if there is any worsening or phlegm progressing beyond, say, a first couple of days. One should be alert to the development of superadded bacterial infection. And if that is associated with maybe fever or recent worsening, maybe you can consider a course of antibiotics at that point of time. So that decision will have to be taken on a case-to-case basis. Beyond 2 weeks, yes. Now TB is also considered to be a kind of a risk factor for development, for future complications, development of severe disease that is in the acute state. But in the chronic state also, or in the post-COVID state, any cough beyond 2 weeks, I think in our country, in the appropriate setting, should be evaluated for possible TB.
Right. Thank you very much, Rajiv.
So now about mucor a little bit. So what is our experience with mucor in the current wave? Are we seeing it as much? And are we recommending the use of antifungals prophylactically?
Okay, before I put it across to our panelists, this wave we've hardly seen as a case of mucor which was preceded by the new variant. We still are getting patients from all over in north of India who had fungal infections after the first wave, and finally they have been able to come to our hospital and get admitted for possible surgeries. I think this is related to practically non-usage of oral steroids or in this phase. Anand, do you agree with this when we talk about this? What is happening to your patients?
Yes, sir. Right. In this phase, we have fortunately not encountered any fresh mucormycosis. That is what I think the question is, because we hardly ever got to with the need to give steroids arose. So even in the last couple of weeks, at least COVID-associated mucor we have not seen in this wave.
Right. Thank you. I think we must put across as far as mucor and steroids are concerned, the carry-home message is that mucor was a fallout of rampant use of steroids in all parts of our country during COVID and even after COVID. So luckily, so far, we don't have any mucormycosis. Rajiv?
Right. So this covers most of the unique questions that we have. There are a number of questions which are repeats of questions which have been addressed previously in this session. There are also a number of questions that are on topics that have been covered in the previous webinars. So if people need those questions addressed, I would suggest they visit the AIIMS telemedicine website and look at the previous webinars on those specific topics to understand, to get their answers. Let me just see if there is anything specific that is left. Okay, I know this is not something relevant to this particular webinar, but anyways, we'll take it. Methylene blue. You've talked a lot about it over the last 2 years. So
yeah, I think we talked about methylene blue during the first phase when we knew nothing about the disease. And we are aware of the fact that methylene blue was used. There were reports from Maharashtra, I still remember, both IV and inhalational methylene blue. Methylene blue in the ICU we use for vasoplastic shock, which is not responding to any kind of medications. And there are reports that patients have survived after the use of methylene blue. We also must know that methylene blue has its own share of problems, and there are reports of pulmonary edema or myocardial depression when methylene blue has been inadvertently given by whatever route. It was used a lot in diagnosing primary or secondary fertility. Kapil, do you have anything to add on use of methylene blue as far as the ICU is concerned?
So, to be straightforward, we didn't use even a single patient methyl blue. Even most of the literature which was there that was pre-COVID, that was isolated case reports or anecdotal case reports. Routine use of methyl blue is not recommended even in the most critical care conditions.
Right. So methylene blue is a big no, and that is very clear. Rajiv, do we have any more questions on this?
Yes, I'll just take the last one here because I think it's coming up again, but it seems pertinent. So I'll just ask this once again. So again, a patient with persistent cough with or without sputum, is there a role of antitussives, antihistaminics in mucolytics?
Okay, I give it to all the three, our panelists, first Saurabh and then followed by Anand and Neeraj. Antitussive in persistent cough.
So, sir, antitussives can be given, but it is better if the patient has, like after 5-6 days of his onset of his illness, it is good to give inhaled corticosteroids because they tend to suppress cough much more than the usual antitussives. If you look at the in general use of antitussive, it is much more than the available literature that cough syrups are more often prescribed rather than they benefit the patient. So I would still go more for an inhaled steroid followed by antitussive therapy.
Neeraj?
Yes, sir. So again, the choice depends. As a pulmonologist, of course, Saurabh will be more inclined towards inhaled steroid. Of course, he has more experience with that. But yes, if you ask me, I will prefer to try any of the antitussives because the persistent cough which we see after say 4 or 5 days, that is more because of reactive hyperreactive airway. In that scenario, of course, a little bit of Livolin and inhaled steroid will definitely help. But initially, I think we should try with anti-allergic and antitussives and see how the patient responds. If the cough progresses or it's not improving, then definitely after ruling out other possible etiology. Of course, we cannot rule out superadded infection. That can also be part of that. So whether the cough is mainly involving the upper respiratory tract or it's more mucoid sputum with say patient has started developing fever, that can be a subtle sign that the patient may have developed some secondary infection or the disease is progressing, the COVID per se is progressing. So after ruling out all those aspects, we have to take a call what specific medications should be used. So I think it has to be individualized based on the presentation of the patient. But yes, initially anti-allergic and antitussives can be tried, and after that we can take it from there.
So Anand, being a pulmonologist, do you give your inhaled steroids faster than Neeraj?
I think I'll club them both together, sir. And I'll just say that in this kind of a situation, we have only 2 or 3 options. We have antitussives, we have a short course of antihistaminics, and we have a short course of inhaled steroids. So there is no harm in giving either of them in any order. We can start with antitussives to be sure, because that is pretty comfortable for everybody. And if it doesn't get drilled, but I would say be alert to the possibility of second.
Yeah, Mara gaya. Mara?
To prevent it from worsening further.
Sorry, there was again some problem with the net here, but I think Anand has summarized this very well. And you should follow your physician, and it should not be over the counter that everybody takes all the 3 things at the same time. Yes, Rajiv.
I think we've addressed most of the issues here. So if everybody would like to wind up, that would be fine.
Thank you very much. I think now I see officers of the Ministry of Health and Family Welfare. We have come to the end of these series of panel discussions. Over to you, sir.
Working as the DDG, the Disaster Management Cell, I convey my gratitude and thanks to all the faculties of All India Institute of Medical Sciences. The special thanks goes to Director, All India Institute of Medical Sciences, Dr. Professor Guledia. On the other hand, I also like to thank and convey my wishes to the participants. If I look into the total number of participants, that varied day-wise from 800 to around 150. But with the hope, especially those from the Indian Medical Association, you have the correct knowledge now. Though you will be having that convenient publishing of that knowledge, kindly percolate that knowledge to the different brethren which we have who are practicing in the field of medicine. So that is my thing. That is my request to all the fellow doctors. And last but not the least, again, great regards and thanks to all the faculty of AIIMS for carrying out such a nicely this 8-day sessions on various aspects of COVID-19. Thank you once again. Thank you.
Thank you, sir. I now finally take this opportunity to thank Dr. Saurabh Mittal, Dr. Neeraj, and Dr. Anand Mohan, Dr. Kapil, and even Dr. Rajiv Kumar, who have been part of these series of panel discussions. I sincerely hope we don't come back with a new variant and some more panel discussions. But in case a need arises, I can assure all participants that we will not be found wanting, and you would still see Rajiv smiling if the next series of panel discussion is to be held. Thank you, everybody, and be safe and wear your mask and have social distancing. Thank you.
Thank you, everyone.